Hi friends, welcome back to the channel Health Dose with Dr. Anik. And today's video is very important and very crucial, so make sure that you watch everything that I'm about to say, that I'm about to record, because these 10 topics will help you throughout your exam. And trust me on this, 60% of the exam is from clinical. So if you are good at clinical, there are very major chances of you clearing your DHA exam in the first go. So kindly watch the video, and if you are new to this channel, kindly hit the subscribe button. I would like to see you again, and it will be my pleasure to get you prepared for your exam and get you successfully done and get your dream fulfilled in Dubai. So the question number one is 60-year-old male on etinolol presents with chest pain twice weekly. BP is 147 over 93. Heart rate is 65 beats per minute. What is the next big step? So next best step is we have the choices: add lisinopril, add amlodipine, add diltiazem, add isosorbide, add isosorbide dinitrate. So the correct answer is add amlodipine. And as you know that chest pain is stable. So it means vasodilator is needed. Stable angina is there as well, so vasodilator is needed. Atenolol plus amlodipine combo is guideline recommended. So ACE inhibitors like lisinopril for CKD and DM, not acute angina control. It is not given for acute and angina control. So the shortcut rule is, if BP is not controlled on beta blockers in angina, add DHP calcium channel blocker. As you know, DHP calcium channel blocker, and if you don't know about it, just leave a comment and I will explain you in the comment section as well. So getting to the second most important topic and most important question that has been consecutively repeated many times in DHA, and if you ask anyone who is experienced in this test giving or writing, so he will definitely or she will definitely say that these questions are the most important ones. So kindly stick with me with all the 10 questions which have been consecutively repeated, and maybe when you are in your exam, definitely you will see them coming and you will know how to tackle them, and then you can say thank you after getting your test pass. Okay, so the second most important topic is diabetes plus metformin plus high creatinine clearance. So in this scenario, what are we going to do the next? So let's hit the example. A 58-year-old male with type 2 diabetes mellitus is on metformin 1000 milligram twice daily for the past 3 years. Recent labs show that serum creatinine is 2 mg per deciliter and eGFR rate is 35 mg per minute. No signs of acidosis or acute illness are there. What is the most appropriate management? A. Continue metformin and monitor renal function monthly. B. Reduce metformin dose to 500 mg twice daily. C. Discontinue metformin and start insulin therapy. D is add empagliflozin for additional glycemic control. So the correct answer is C, discontinue metformin and start insulin therapy. Now, how is this going to happen? Why is this going to happen? Because metformin is contraindicated when eGFR is less than 30 ml per minute. Due to increased risk of lactic acidosis, it is very essential to know the lactic acidosis symptoms. So if they are occurring in the patient, one has to know that these are actually going to happen. So I'm really sorry with the noises at the background. I'm trying my best to find the cold spot. Even the fans are turned off, so just deal with it. Okay, why not the others? So I will explain why A is not good, why B is not good, the good of the answer, not why D is not a good answer. So A, because continued full dose of metformin at the EGFR is at the current EGFR is unsafe. B, dose reduction might be considered at EGFR greater than 45 but not less than 40. And D, SGL2 inhibitors such as empagliflozin are not effective below EGFR 45. Okay, so what is the shortcut rule over here? EGFR is greater than 45. Be cautious with metformin, and if EGFR is less than 30, stop metformin. Well, the symptoms of lactic acidosis are very important because uh, if there is abdominal pain, confusion, tachypnea, which means abnormally rapid breathing, and elevated lactate levels, these are the symptoms which are going to tell you if the patient is going under lactic acidosis or not. Number three, and the most important one, because if you are going to skip this one, you are definitely going to lose 7 to 8 MCQs, and 7 to 8 MCQs will definitely come from this topic. If not, then 5 MCQs are nowhere, they will definitely come. So let's hit with the example. An 82-year-old male with non-valvular atrial fibrillation and hypertension is being evaluated for anticoagulation therapy. He has mild cognitive decline and lives alone. No history of bleeding, creatinine clearance is 55 ml per minute. You must initiate long-term anticoagulation. Which of the following is the best choice? A, warfarin with regular and INR monitoring. B, apixaban 5 mg twice daily. C, rivaroxaban 20 mg once daily, and D is aspirin 81 mg. So the correct answer is definitely apixaban 5 mg twice daily. Why? In elderly patient, direct oral anticoagulants are safer and more effective than warfarin for stroke prevention in non-valvular AF. Apixaban has shown lower bleeding risks as well. So there is, especially in intracranial hemorrhage, compared to warfarin and even other DOACs, direct oral anticoagulant. Warfarin requires frequent INR monitoring, has many food and drug interactions, as you know it or not. This drug is a very critical drug, so if you are actually giving it to someone, you have to monitor them very, very critically. And aspirin is not effective for stroke prevention in atrial fibrillation, as you know it. So what we are actually getting at is apixaban is the safest choice. So please remember one thing, that avoid warfarin unless patient has mechanical valve, rheumatic mitral stenosis, or severe renal failure. Well, as for apixaban, in patients greater than 80 years or equal to 80 years old, or weight is less than 60 kg, or creatinine is less than or equal to 1.5 mg per deciliter, reduce the apixaban dose to 2.5 mg BID if 2 out of 3 criteria are met. And these are the 3 criteria: age, weight, and the creatinine clearance. So the next most important one is AST/ALT raised in TB patient. So as you know that these are the liver enzymes, they are checked in LFT test, and most of the time the drugs in the TB therapy, they are hepatotoxic, and they actually increase the ALT and ASTs. So they have a ratio, and if the ratio is increased, so it means we have to check which drug is there which is actually causing hepatotoxicity, and we have to stop it first. Then we have to check with the liver function test, and then I will explain it further. So let's hit the example. A 35 years old male is on first line anti-TB therapy. He is taking RIPE regimen. As you know, RIPE, R stands for rifampin, isoniazid, pyrazinamide, ethambutol for pulmonary tuberculosis. After 3 weeks of therapy, he presents with fatigue, nausea, and dark urine. Well, these side effects are very critically to be noted, and liver function test shows AST is 290 international units per liter and ALT is 320 international units per liter, and total bilirubin is 3.1 mg per deciliter. Which of the following drugs should be stopped first? A. Rifampin, B. Isoniazid, C. Pyrazinamide, and D. Ethambutol. So as you know that most hepatotoxic is pyrazinamide, and all RIPE drugs except ethambutol can be hepatotoxic, but pyrazinamide is the most hepatotoxic of them all. So they have to be stopped first. When hepatotoxicity occurs, guidelines recommend stop all hepatotoxic drugs such as isoniazid, rifampin, and of course pyrazinamide. Continue ethambutol and streptomycin if necessary, and reintroduce drugs one by one. For example, if you are starting with rifampin, which is the least hepatotoxic, then check with the LFT test, and if it is okay, then you can introduce isoniazid, then check the LFTs. If the LFT reports are still same and good, then you can add the pyrazinamide in the last. It is very important that you always monitor LFTs monthly in TB patients, especially if they have risk factors such as alcohol use, HIV, malnutrition, liver disease. Number 5th most repeated topic and MCQ is amoxicillin allergy. Which antibiotic is safe? It has been asked very commonly and repeatedly in all the tests. So antibiotics, these are very important, specifically amoxicillin, and let's hit the example and you will get to know more about it. A 28 years old female presents with acute sinusitis. She has a documented history of immediate hypersensitivity reaction to amoxicillin, developed urticaria and shortness of breath 30 minutes after ingestion. She now requires antibiotic therapy. Which of the following antibiotics is the safest alternative? A. Cephalexin, B. Azithromycin, C. Cefuroxime, and D is amoxicillin or clavulanic acid combination. As you know, the correct answer is azithromycin, because immediate hypersensitivity to amoxicillin, which will lead to anaphylaxis, urticaria, bronchospasm, indicated at type 1 IgE mediated allergy. So in such cases, avoid all the penicillins, specifically first and second generation, because there are 5 to 10% chances, because the cross reactivity is still going to happen. It has been reported and seen with the clinical experts that it has been done, and so we choose an antibiotic from a different class, and that is macrolide, like azithromycin. Cephalexin and cefuroxime carry a risk of cross reactivity, and amoxicillin and clavulanic acid contains amoxicillin, absolutely contraindicated. So what is the quick rule over here? That in IgE mediated penicillin allergy, it is important to avoid penicillins and early generation cephalosporins as well. Use macrolides, azithromycin such as, or doxycycline if it is appropriate. So avoid first and second gen. Third and fourth gen, they have very low chances of cross reactivity reactions such as ceftriaxone, but still use it with caution in your mind and in your practice as well. So it is better to ask the patient if he or she has ever received any symptoms with reactivity or allergic reaction. So if not, so you can always check the patient history, or if there is nothing else that you can do to find out, always go for allergy tests and you will get to know. 6, and the most important topic among these 10 is antidote for paracetamol overdose and acetylcysteine. As you know, let's hit the example to get to know it better. A 19-year-old female presents to the emergency department 6 hours after an intentional ingestion of 20 grams of paracetamol. She is conscious and vital signs are stable. Laboratory results show ALT is 215 international units per liter and AST is 180 international units per liter. Serum paracetamol level is above the treatment line on the Rumac-Matthew nomogram. So I hope you have heard about this one, Rumac-Matthew nomogram. What is the most appropriate next step in the management? A, administer activated charcoal. B is start N-acetylcysteine. C is give intravenous vitamin K. And D is monitor LFTs and reassess in 12 hours. Aspirants, always remember that MCQs have been the chosen one, the knight in the shining armor from the international testing authorities, because of one reason, and this reason is student can get easily confused. But in our field, it has been said over and over again by our professors as well that if you take a wrong decision, the patient is dead. So we cannot afford to basically do anything like a mistake. We have to be very well at what we do, because it is about patient's life, and we have to make sure that nothing is ever going to be against the health and wellness of the patient. So guys, always remember that in an MCQ there are 4 options. Coming back to the point, so the correct answer is start N-acetylcysteine. N-acetylcysteine is also an AC. So paracetamol overdose is a very common cause of liver failure and also for liver cancer as well. And acetylcysteine replenishes glutathione, which detoxifies the toxic metabolite, that is NAPQI, NAPQI. And NAC is most effective if given within 8 to 10 hours, but still it is beneficial if this time limit is delayed as well. The Rumac-Matthew nomogram guides the treatment of single acute ingestions after 4 hours. Activated charcoal is only useful within 1 to 2 hours of ingestion. So what is the quick rule over here? Paracetamol overdose, it means NAC is the antidote, and use the nomogram if within 24 hours. Let's hit the 7th most important case and 7th most important, most repeated MCQ that has been repeated over and over with time, and it is vancomycin TDM case. And it is very common to get this question in your DHA exam, because trust me guys, this can come anytime, anywhere, in any test. It doesn't matter if you are preparing now or you have been given the exam in 2024. So this question is the most favorite for DHA examination centers And let's hit the example and you will get to know about it. A 65 years old male with MRSA pneumonia is started on IV vancomycin 1 gram every 12 hours. He has a stable renal function. Creatinine clearance is 80 ml per minute, and you are asked to monitor vancomycin therapy. When should you draw the first vancomycin trough level to assess dosing adequacy? A. 30 minutes after the first dose. B. Immediately after the second dose. C. 30 minutes before the fourth dose. And D. 2 hours after the third dose. So the correct answer is C. 30 minutes before the fourth dose, and let me explain why. Trough levels are drawn just before the next dose. So typically 30 minutes before the fourth dose, assuming dosing is at steady state. If nothing is mentioned, we have to assume that it has to be steady state dosing. So for vancomycin, steady state levels are usually reached after 3 to 5 half-lives, which aligns with the drawing before the fourth dose in patient with normal renal function. And the other choices, why they're wrong: A is too early, not a trough. B is second dose is too soon to reach steady state. D is 2 hours after, which is a peak level not used for vancomycin TDM. Okay, so always remember this quick rule about vancomycin trough: 30 minutes before 4 dose at steady state. All right. The plus points are that for cellulitis and UTI, 10 to 15 microgram per ml concentration is required in order to treat this infection. And for pneumonia, endocarditis, osteomyelitis, 15 to 20 microgram per ml is required of vancomycin in your blood in order to treat this specific infection. Okay. One has to know what are the differences between asthma and COPD. Of course, I will explain them. And let's hit the example. A 55 years old male ex-smoker, to be noted, presents with chronic cough, to be noted, shortness of breath and wheezing. For the past 2 years, symptoms worsen with exertion, and in winter, pulmonary function tests show ratio, that is FEV1 slash FVC ratio, it is 65%. So 65% means that not fully reversible with bronchodilators, mild hypoxia on room air, and diagnosed with COPD, cold stage 2. Which of the following is the most appropriate initial maintenance therapy? A. Salbutamol as needed. B. Inhaled corticosteroids, ICS. And C. Long-acting beta blockers, LABA. And D. LAMA, long-acting muscarinic antagonists. The answer is, of course, D. Long-acting muscarinic antagonist, LAMA. For COPD, it should be remembered that the first line maintenance therapy based on gold guidelines is either LAMA or LAVA, depending on the symptoms. So LAMA is particularly effective for reducing the exacerbations, improving symptoms, and lowering the hospitalizations. And in asthma, ICS is the first line, but in COPD, ICS is not used as monotherapy. It's a very important point because it carries a risk of pneumonia if you are giving it in COPD. Well, why not others? A. Salbutamol is for quick relief, not maintenance. It should be remembered that it is for quick relief. And B. ICS is not the first line for COPD unless there's eosinophilia or frequent exacerbations. And C. LABA can be used, but LAMA is preferred initially in many moderate COPD cases. Let's get the key differences noted and written down. Asthma starts with ICS and COPD starts with LAMA or LABA depending on the uh, s- uh, symptoms, and ICS only later if needed, but it can't be given alone. It is given in combination therapy. The second last, the most important topic among the 10 is ceftriaxone in neonates. So why it is avoided? It is very important to know as what is connectaris and what it actually does with the brain, and what actually ceftriaxone does in order to free the causative agent in the blood and making sure that it crosses the blood-brain barrier. Let's hit the example and we will get to know it for sure. A 5-day-old neonate is diagnosed with suspected sepsis and requires empiric IV antibiotic therapy. The junior doctor suggests ceftriaxone as part of the treatment plan. As the pharmacist, what is the most appropriate response? A. Ceftriaxone is safe and effective in all neonates. B. Ceftriaxone is avoided due to high risk of connectaris. C. Ceftriaxone has poor CNS penetration in neonates, and D. Ceftriaxone is nephrotoxic in neonates. So, as you know, that the correct answer is B. Ceftriaxone is avoided due to the risk of connectaris. Now let's see what is the explanation behind this. Ceftriaxone is contraindicated in neonates. It can displace the bilirubin from albumin, increasing free unbound bilirubin, and which can cross the blood-brain barrier and lead to the connectaris, a form of brain damage due to high bilirubin concentration in the brain cells. And it can also precipitate with calcium containing IV solutions, leading to fatal lung or kidney deposits in the neonates. In neonates, avoid ceftriaxone at all cost. Risk of connectaris is there, plus calcium precipitation. Connectaris, as you know, it is a type of brain damage caused by excess unconjugated bilirubin crossing the immature blood-brain barrier in neonates. So, uh, cefotaxime is preferred, safe, good CNS penetration, and no bilirubin displacement has been seen, and often used in neonatal sepsis and meningitis as well. Important interaction to remember is ceftriaxone plus calcium IV in neonates. It will cause fatal precipitation, so avoid using both together even in older infants unless necessary. The last but not the least is statin and gemfibrozil interaction case, and let's hit the example to know what is actually trying to tell us. A 62 years old male with a history of type 2 diabetes, hypertension, and dyslipidemia is on atorvastatin 40 mg daily. His recent lipid profile shows elevated triglycerides, that is 470 mg per deciliter. The physician considers adding a gemfibrozil to further lower the triglycerides. As the clinical pharmacist, what is the most appropriate recommendation? A. Approve the gemfibrozil addition and close LFT monitoring. B is recommended switching atorvastatin to rosuvastatin. C. Recommended avoiding gemfibrozil due to increased risk of myopathy, and D is suggest increased atorvastatin dose to 80 mg daily. So the correct answer is, of course, C. Recommend avoiding gemfibrozil due to increased risk of myopathy. So gemfibrozil strongly inhibits CYP2C8 enzyme and glucuronidation as well, which are key in statin metabolism, especially atorvastatin and simvastatin. So co-administration significantly increase the plasma statin levels and leading to increase the risk of myopathy and rhabdomyolysis. The combination should generally be avoided, and if triglycerides lowering is needed, fenofibrate is safe fibrate to use with statins. So what is the key rule here? Camfeprozil plus statin, it is giving a high risk of rhabdomyolysis. Use fenofibrate if fibrate is needed with statins. What is the bonus clinical note over here? As you know, I always give the bonus tips to the students and all the aspirant pharmacists over there who are actually watching this channel on daily basis and are the subscriber of my channel. Well, myopathy risk factors are always there in older age, renal impaired patients, hypothyroidism patients, high statin dose, and drug interactions, especially fibrate, macrolides, azoles. In these risk factors, myopathy is always there. So if you don't know what is the meaning of rhabdomyolysis, it is the breakdown of skeletal muscle tissue releasing toxic contents like myoglobin and CK, also known as creatinine kinase, and potassium into the bloodstream, leading to renal failure, hyperkalemia, and even death if not treated promptly. So always remember this: 80% of the success is smart preparation and not long hours of preparation. You know, one can study for 8 to 10 hours on daily basis, but still you can do far much better than him or her if you are doing it smartly. So practice real clinical thinking, not just theory. And if you master these 10, you're ahead of the 90% students already, and you're on road with your success and in fulfilling your dream to become a pharmacist, a health professional in Dubai. So if you haven't subscribed the channel, please subscribe.